Good morning, everyone. My name is Dr. Melanie, Senior Resident in the Department of Orthopedics, Sri Lakshmi Narayan Institute of Medical Sciences, Puducherry. Today, I'll be talking about post-surgical, post-operative osteomyelitis. In developing countries like India, uh, infrastructure and strict aseptic environment in the pre, intra, and post-operative area is not always available. Even in advanced countries, infection rate in internal fixation and joint replacements do occur. Operative treatment uh, converts a closed fracture into an open fracture and introducing an implant, which is a foreign body, both together increase the chance of infection considerably after such surgery. Rothwell et al. And Winquist et al. In 1978 showed that incidence of 1% in close intramedullary nailing, and there is a 2 to 9% of chance of postoperative osteomyelitis in open nailing of closed femoral fractures. An analysis of 6,000 operated cases over a period of 5 years showed that 0.5% occurred in soft tissue procedures, whereas infection rate in bony procedures was 15%. Charnley brought down the infection rate in replacement surgeries from 9% to 1% by introducing clean air systems. What are the changes that occur around the implant? Physiological and pathological changes take place in and around the implant, and this can occur in 4 phases. First, the surface reaction of the metallic implant, bacterial colonization and microbial adhesion, influence of implant design and material, and immunomodulation by metal implant. What happens in a normal aseptic tissue environment? The surface of a freshly implanted device is destined for 2 fates: bacterial adhesion and colonization, or tissue integration. Whenever a metallic device is implanted successfully, biointegration requires that host cells colonize the highly reactive implant surface. All implants are prone to react to implant-associated inflammation. The implant-related reaction is a series of interactions. So the immediate reaction that occurs is adhesion of proteins derived from the blood and tissue fluids at the wound site. In addition to this, electrolytic changes occur, resulting in formation of denatured tissue in contact with the implant. Ultimately, the surface proteins of the implant is coated with matrix of serum proteins, ions, cellular debris to which bacteria get adherent through their cell membrane receptors, which is your glycocalyx mucopolysaccharide biofilm. This biofilm provides a base for which both host cells and bacteria compete with each other to colonize. The end result of this process depends on the predominance of host cells of local immune system of the host and the virulence of the bacterial colonies. If eukaryotic host cells integrate themselves into the surface first, bacterial colonization will be actively inhibited and the biomaterial will be biointegrated. On the other hand, if the bacterial cells colonize the surface first, it will establish a conducive bed for further bacterial growth and inhibit host immunoresponse. Hoyle-Jones et al. Said that the biofilm bacterial colonies are protected from phagocytic cells as well as from antimicrobial agent. The biofilm bacteria are enveloped by an extracellular polymeric substance matrix. This biofilm not only limits the effectiveness of antibiotics, it also limits the usefulness of cultures as the organism is protected within the biofilm. Other factors contributing to post-surgical osteomyelitis are the specific organism that is growing, the type of material that is used, the surface of the implant, whether it is dense or porous, the configuration of the implant, whether it is solid or hollow, the timing of the bacterial colonization, and the local and general health of the host. How does the implant design and material influence this? Bacteria adhere differently to different substances. Chang and Merritt stated that bacterial adherence to stainless steel is greater than to polymethyl methacrylate and titanium. Specific biomaterial affects the efficiency of bacterial adhesion. Example is coagulase negative staphylococci exhibit preferential adhesions to polymers, whereas coagulase positive staphylococci adhere more readily to metals. Surface characteristics. Porous surfaces allow more bacterial colonization. The probability of bacterial adhesion increases with the size of the implant and may interfere with surface and tissue integration due to increased surface area. Basically means that a larger implant has greater bacterial adhesion. Finally, the shape of the implant may create a dead space which harbors bacteria. Therefore, there's higher susceptibility of infection in intramedullary nails. Immunomodulation by metal implants. Ideally, metallic implants should be inert in the body. However, no material is completely inert and interaction is inevitable. This interaction takes place at two levels: the local host response, and the general systemic response. How do we diagnose a post-surgical osteomyelitis? In the post-operative period, the patient is carefully monitored. Pain and fever are the most important signs. Persistence of these symptoms after 72 hours are cause for worry. The general well-being of the patient and sense of comfort is disturbed beyond the second or third day. The patient may complain of throbbing pain at the site. Edema may persist or appear in the fingers or toes beyond the plaster or any type of splintage. All wounds are inspected after 48 to 72 hours under aseptic precautions. The wound condition is noted. Tension and edema around and in between the sutures, or if there's induration around the wound, and we assess the quality of discharge and tenderness around the area. What is imminent infection? Persistence of pain and fever accompanied by signs like tension, edema, induration, and sometimes serious discharge after 72 hours indicate an imminent infection. Laboratory investigations play only a supportive role. Leukocytosis and persistent rise of ESR and C-reactive protein are indications of osteomyelitis. If imminent infection is missed, there may be persistent low-grade fever, pain, and dressings may get soaked. This is the intermediate stage. By the 12th to 15th day, when the stitches are removed, there may be signs of frank infection, like interrupted wound adhesions with induration, edema, and discharge. If after 3 weeks, discharge with sinus-like opening persists, a diagnosis of deep infection has to be made. We take an X-ray in case of suspected post-surgical osteomyelitis. There will be scattered foci of osteolysis and osteoporosis around the implant, and later periosteal reaction and bone resorption around the implant. Sometimes there may be skin necrosis due to tension during closure of the wound. This may lead to implant exposure, especially in a plate fixation. Doubtful cases, a radionuclide studies can be done, or an MRI, or aspiration under fluoroscopic guidance and analysis of the fluid. If the joint is open, intraoperative investigations can be done. WBC count of the synovial fluid, analysis of frozen section, culture and gram staining of the material obtained from the pseudocapsule. Coming to how do we treat cases of post-surgical osteomyelitis? First thing is prevention. Prevention is better than cure. Integrated approach involving the surgical team and the infrastructure available helps in optimizing the wound environment, minimizing contamination, and improving patients' health condition. What are some of the preoperative steps that can be taken in this case? Assess the patient's general health, evaluation of the operative site, and identification of remote source of infection, if any. Obese patients, diabetics, and those on immune suppressive drugs, especially steroids, are at a higher risk for infection. Prolonged hospitalization just before operation has also been associated with prevalence of infection. There has been differing opinion about preoperative shaving, resulting in colonization of small nicks, and should be done just prior to surgery. The patient's clothing and linen should be removed, and clean linen should be used before transferring the patient to the operation theater. Preoperative antibiotics. In developing countries, every operation is potentially infected or likely to be contaminated due to inadequate infrastructure. Hence, most Indian surgeons administer antibiotics for prolonged periods. Systemic antibiotics prophylaxis is used in implant surgery. The disadvantage of this approach is that one can miss signs of imminent infection. Ideal antibiotics should be active against streptococcus and staphylococci. Um, they should be able to penetrate tissue easily and have a half-life to provide coverage for the duration of the surgery and should be relatively non-toxic. We should choose a broad-spectrum antibiotic like cephalosporins, and it can be combined with aminoglycosides depending on the situation. The timing of administration is within 30 to 60 minutes before skin incision. For prolonged procedures associated with extensive blood loss, an additional intraoperative dose is advised. Most authorities recommend a single preoperative dose followed by 2 to 3 postoperative doses. In India, most administer for at least 5 days postoperatively. Coming to intraoperative period, how can we prevent? Prevention of infection in the intraoperative period consists of monitoring several areas related to the intraoperative time period. One is the operating room environment, the wound environment, and the implant selection. A clean operative room environment depends on achieving clean, circulating, and particle-free air. Discipline of personnel and methods of reducing bacterial contamination. The OT air can be kept free of bacteria and particles by different methods, from ultraviolet light to laminar flow technique. Minimum standards, that is dustproof air, double door entry, keeping windows closed, limit the foot traffic inside OT and no street clothes, use of face masks, surgeon's gowns, drapes, double gloves while performing surgery, routinely changing the outer gloves during procedures that last more than several hours, and changing the suction tip at 30-minute intervals. The wound environment, antiseptic cleaning of the skin prior to skin incision, appropriately placed incisions, gently handling the tissue, minimum dissection, and observing scrupulous hemostasis helps reduce infection. Meticulous closure of the wound, layer by layer, prevents development of hematoma, commonly identified as a factor for infection. Closed suction drains are required where tense hematoma is expected. Monofilament absorbable synthetic suture is associated with lower rate of infection. How would one treat an imminent infection? The wound should be immediately inspected, preferably inside the operation theater. Mukhopadhyay suggested opening of the wound, limited debridement, closure if the edges can be opposed without tension, but no prophylactic antibiotic. Hansen suggested serious wound discharge may be treated initially with compressive dressing and antimicrobial coverage to prevent retrograde introduction of bacteria into the wound. However, continued drainage mandates a debridement. Most surgeons prefer an aggressive management at this stage with use of prolonged antibiotic therapy. Some stitches removed if there is tension, a compression bandage applied, and wait. In case of persistent discharge, debridement needs to be done. Wound should be irrigated with antibiotic solution and a suction irrigation system can be set up if required. Finally, come to treatment of an established infection. The wound should be opened up to the bone and all granulation tissue should be removed. Dead tissue should be excised and a bleeding area left behind. If healthy bleeding surface is achieved, the wound may be closed either with antibiotic beads inside or suction irrigation with antibiotic solution. In osteomyelitis, the intramedullary implants get surrounded by granulation tissue and intramedullary cortical absorption takes place, leading to loosening of the implant and an unstable fixation. The primary goal is to achieve fracture union while controlling the infection by debridement and antibiotics. After debridement, removal is sequestrum, irrigation of fracture site, as well as the medullary canal should be done in case of intramedullary nailing. Corticotomy may be made of the medial aspect of distal femur to allow thorough irrigation. The stability of fixation should be assessed. If stable, the nail can be retained and antibiotics that are culture specific has to be administered for 6 weeks. Stability should be regularly assessed while antibiotic treatment is continued. If after fracture union, signs of infection are still present, implant can be removed and after further debridement and irrigation of medullary canal, the infection usually heals. Implant infection with instability as demonstrated by mobility at fracture site, swelling, inability to bear weight in that limb, with loosening of fixation and X-ray needs removal of implant and debridement. If large area of bone is involved, antibiotic beads or suction irrigation with antibiotic solution can be used. Fixation of the fracture can be done either by reamed exchange nailing or by external fixation. Sometimes skin loss or wound adhesion can lead to bone exposure or implant exposure in cases of plate fixation. And the following recourse can be taken to obtain skin cover: either a local rotation flap, a cross-legged full thickness skin graft, a muscle pedicle graft, microvascular graft. If necessary, bone graft can be combined with these reconstructive procedures. Now, the treatment of periprosthetic infection differs from infective implants like nails or plate. First, it can present in various stages, either early acute onset, delayed acute onset, or chronic onset. In case of early acute onset, aseptic aspiration needs to be done and sent for culture gram staining. Parenteral antibiotics After cultures, uh, parenteral antibiotics can be started after cultures are taken. Once we get the culture result in 1 to 5 days, appropriate IV antibiotics can be given for 6 weeks. Another option in case of early acute onset is an immediate surgery. Many cultures are taken at this point, debridement and irrigation, and can retain the prosthesis. Antibiotic beads can be placed, a hemovac suction can be applied, and primary closure. And repeat the surgery in 3 to 5 days if signs and symptoms of sepsis persist. Remove the antibiotic beads in 4 to 6 weeks. Delayed acute onset. Aseptic aspiration can be done and sent for culture gram staining. A bone scan can be done, which is the three-phase gallium or indium 111. Again, we can follow the flowchart where immediate surgery can be done with multiple cultures and debridement, retaining the prosthesis and insertion of antibiotic beads, and repeat the surgery after 3 to 5 days, and after 4 to 6 weeks, the antibiotic beads can be removed. Else, another option is if the prosthesis is loose, remove the components and treat as in chronic sepsis. In the case of chronic sepsis, an arthrogram is done. Arthrogram can be done, a cyanogram, multiple cultures, and bone scan. Based on that, a radical surgery can be done where we remove the components, and culture and gram staining can be sent, and antibiotic beads are placed. After 3 to 5 days, a debridement can be done based on the culture sensitivity. Parenteral antibiotics therapy can be started for 6 weeks. Now, following that, various options are available. First is girdle stones. This is done in elderly patients. This is a painless, high risk, it's painless procedure. Sorry, it's elderly and those who do not have any pain. It can be done in high risk patients for another surgery, gram negative or mixed infection, or in case of immunosuppressed individuals. The next option is fusion. In case of persistent drainage, in spite of repeated surgeries, a fusion is done, or in case of gram negative or mixed infection. Disarticulation. In those with severe pain, life-threatening and intractable infection, or severe bone loss, a disarticulation can be done. Or the other option is delayed exchange. More than 6 weeks can be done after more than 6 weeks for less virulent organisms like Staphylococcus coagulans negative, beta streptococcus, etc. Or in the case of virulent organisms like Staphylococcus coagulase positive, gram negative bacteria, or mixed infection, the delayed exchange can be done more than 12 weeks of antibiotic treatment. Following this, an antibiotic cemented arthroplasty can be done, or a porous in-growth prosthesis with autogenous bone grafting. Coming to how would one treat an infected TKR? Again, if there is an early acute onset, in the case of delayed acute onset, and in the case of a chronic osteomyelitis. In case of early acute onset, the diagnostic criteria for this are the signs and symptoms, and the aspiration is sent for gram stain and culture. Here, either an immediate surgery, can be done. During the surgery, several cultures can be sent. Debridement and irrigation is done. Retain the component, start cephalosporins after the culture is taken, and antibiotic beads can be placed. Once the culture report comes, it can be shifted over to appropriate Antibiotics, which needs to be continued for 6 weeks. Remove the antibiotic beads in 2 weeks. Keep the knee immobilizer and active ROM at intervals. In case of delayed acute onset, this is based on the signs and symptoms. An aspiration can be done and sent for culture. Bone scan, in this case, the technetium bone scan, 3-phase, which is or a gallium or indium scan. If it's a negative bone scan and the process is not loose, we can continue continue management the same as we've done for an early acute onset. However, if there is a positive bone scan or a prosthesis is loose, we continue as per the management for chronic case. In the chronic case, there is usually a draining sinus. An X-ray will show loosening of the prosthesis and bone loss. A bone scan is done, and if we get a positive bone scan, along with the loose prosthesis, a lateral surgery needs to be done. First, a debridement and irrigation. Remove both the components. Tobramycin beads are placed. Cement block is used, and primary closure, along with plaster splints. This is continued for 2 weeks and then can go on to arthrodesis, or it can continue for 6 weeks and then move on to exchange arthroplasty, cemented components with tobramycin in the bone cement, or as last resort, a resection arthroplasty or amputation may be required. Thank you.